We'll be breaking down all major concepts covered on the exam. Picture walking into an exam room and, percussing an infant skull, only for it to echo with a sound like a cracked pod. Or imagine an 82-year-old patient whose feet seem mysteriously glued to the floor, like completely unable to take a single step.
Yeah, those are classic high-yield scenarios.
Right. Well, today we are looking at the intricate plumbing of the human brain. Welcome to this deep dive, specifically curated to help Canadian medical students master material for the MCCQE. Today's target is section S08 Neurology, and we are zeroing in on the mechanisms, presentations, and those tricky board traps of hydrocephalus.
And as always, we rely on evidence-based material for these reviews. So the foundation of today's clinical and anatomical breakdown is drawn straight from reliable StatPearls articles.
Always good to have solid sources.
Exactly. And hydrocephalus is such a high-yield topic because it really forces you to connect gross anatomy with fluid dynamics and, clinical pathology.
Definitely. But real quick, before we jump into those fluid dynamics, just a brief clinical disclaimer. This deep dive is strictly for medical education purposes. It is not medical advice, and all clinical decisions in your actual practice should involve a qualified healthcare provider.
Right, absolutely. So getting into it, the clinical definition of hydrocephalus is basically the symptomatic accumulation of cerebrospinal fluid, or CSF, inside the cerebral ventricles.
Symptomatic being the key word there.
Yeah. But to truly understand how to diagnose a leak or a blockage on a board vignette, you really have to intimately understand the normal path of that fluid.
Let's trace that exact normal path then. If I'm picturing the brain's ventricles like, a series of interconnected caverns, where is this fluid actually being generated?
Well, the primary water source is the choroid plexus. It's this network of specialized blood vessels and ependymal cells located mainly within the lateral third and fourth ventricles. It basically constantly filters blood to create clear CSF.
Okay, so from the lateral ventricles, the fluid has to drain downward, right?
Right. It passes through the paired foramina of Monroe and dumps into the third ventricle.
And the third ventricle, it sits right in the midline of the brain, and it has only one way out. It's this very narrow pipe called the cerebral aqueduct, or the aqueduct of Sylvius.
Yeah, and the narrowness of that aqueduct makes it probably one of the most vulnerable bottlenecks in the entire central nervous system.
It's tiny.
It really is. So once the CSF squeezes through that aqueduct, it reaches the fourth ventricle. And from there, it needs to exit the interior of the brain and get out to the surface.
And it does this by flowing through three specific openings, right? The two lateral foramina of Luschka and the single median foramen of Magendie.
Exactly. That allows the fluid to enter the basal cisterns, which are basically these large holding pools at the base of the brain. From there, it washes around the spinal cord and flows all the way up over the outer surface of the brain.
But it doesn't just sit there.
No, it gets absorbed by the arachnoid granulations. They act like these little one-way pressure valves, just dumping the old fluid into the venous system, specifically the superior sagittal sinus.
Got it. So the volume of this system is where the pathology really begins to make sense for the exam. Because a healthy adult has about 150 milliliters of CSF circulating at any given time.
Right. But the choroid plexus is producing roughly 500 milliliters every single day.
That's a huge difference. So applying like a running bathtub analogy, the faucet is pouring in 500 milliliters a day, but the tub can only hold 150?
Yeah, the entire volume of fluid is being replaced more than 3 times every 24 hours.
So the only way the brain doesn't overflow is if the drain is working at the exact same speed as the faucet. What actually happens when that drain clogs even slightly?
Well, then we hit a physics problem governed by the Monroe-Kelly doctrine.
Right, I remember that one.
Yeah, the Monroe-Kelly doctrine dictates that the human skull is a rigid, unforgiving box. Inside this closed box, you essentially have 3 components. You've got brain tissue, blood, and CSF.
And the total volume has to remain constant.
Exactly. If the volume of the CSF increases because of a blockage, it must physically displace one of the other 2 components.
But you can't simply squish brain tissue without causing massive neurological deficits, and you obviously can't squeeze out the blood supply without causing ischemia and cell death.
Right, you can't. So the immediate result is elevated intracranial pressure.
So where does that trapped fluid actually go when the pressure spikes? I mean, it has to go somewhere.
It gets forced outward. The pressure pushes the CSF straight through the ependymal lining of the ventricles and into the surrounding spongy white matter of the brain.
Oh, wow.
Yeah, this is called transependymal extravasation. The fluid physically invades the brain tissue, and over time, That chronic pressure literally crushes the surrounding cells, leading to pressure-induced atrophy.
Okay, so if the closed box is full, what actually clogs the drain or blocks the pipes in the first place? For adults, we categorize this chaos into four distinct types,
Right.
right?
4 types.
The first is obstructive or non-communicating hydrocephalus. So in our bathtub analogy, this would be a blockage in the pipes between the ventricles.
Exactly. And the blockage is almost always a physical mass effect.
Yeah.
Tumors like ependymomas, subpendymal giant cell astrocytomas, or craniopharyngiomas, they can easily compress that narrow aqueduct of Sylvius we mentioned earlier, halting the flow of CSF completely.
Okay, and the second type is communicating hydrocephalus. So here, the pipes between the ventricles are wide open, meaning the fluid can communicate all the way out to the surface of the brain, but the drain itself is broken.
Right. The arachnoid granulations just fail to absorb the fluid.
And what causes that?
The pathophysiology usually involves debris physically clogging those microscopic arachnoid granulations. Subarachnoid hemorrhage actually accounts for a full 1/3 of these cases.
Because the red blood cells from the bleed travel through the CSF and physically jam the one-way valves.
Exactly. You see a similar mechanism with bacterial meningitis, where severe inflammatory exudates and subsequent scarring literally glue those granulations shut.
Wow. Okay. So the third type is hypersecretory hydrocephalus, which I know is rare, but heavily tested. Here, the pipes are open, the drain works, but the faucet is just running too fast.
Right, this is an overproduction of CSF, classically caused by a choroid plexus papilloma.
And the fourth category is normal pressure hydrocephalus, or NPH.
Yeah, this is a fascinating subset of communicating hydrocephalus affecting the elderly. The CSS dynamics are impaired, but intriguingly, the overall intracranial pressure remains relatively normal or maybe only episodically elevated.
Right.
The pathogenesis here is notoriously complex and honestly not entirely understood, but the clinical presentation is heavily tested.
We will definitely break down how NPH looks on a vignette, but this isn't just an adult pathology. Congenital causes are a major testing focus too.
Oh, for sure. Brainstem malformations that cause stenosis of the cerebral aqueduct account for roughly 10% of all newborn cases.
And Dandy Walker malformations too, right? Where the fourth ventricle becomes massively cystic.
Yes, those make up another 2 to 4%. You also have Arnold-Chiari malformations and, importantly, intraventricular hemorrhage, which is a massive risk factor for premature infants.
Which perfectly brings up the epidemiology curve. The global prevalence is about 85 cases per 100,000 people. But if you look at a graph, it's not a flat line at all.
No, it's a massive bimodal distribution.
Right, you have a huge spike in infants, a drop in middle age, and then a staggering leap late in life. For people over 80, the prevalence skyrockets to over 400 per 100,000.
And that's almost entirely driven by NPH. That bimodal curve is your first major diagnostic clue on the MCCQE.
So for exam purposes, if a clinical vignette presents an infant, we should immediately think congenital malformations or premature bleeding, but if the patient is 82, we should lean heavily toward NPH.
Absolutely. That bimodal distribution is a classic exam pattern. The staggering jump in prevalence for those over 80 makes NPH a high-yield diagnostic consideration for literally any geriatric vignette.
Okay, let's translate that stretchy versus rigid skull distinction into physical exam findings in the emergency department. In an infant, the cranial sutures haven't fused yet. The skull can actually physically expand to accommodate the trapped fluid.
Right, so the primary sign is macrocephaly, an unusually large head. Upon palpation, the anterior fontanelle will feel remarkably tense and bulging, rather than soft and flat.
And the scalp itself stretches, right, becoming thin and shiny, making the underlying veins highly visible.
Yes, and you may also observe the setting sun sign, where the infant's eyes are driven downward, exposing the white sclera above the iris.
And then there is the Macewind sign. If you percuss that infant's skull, you hear a cracked pot sound.
Which is wild to think about.
It is. The physics behind that sound is that the internal pressure has actually separated the cranial sutures, altering the acoustic resonance of the skull.
Exactly. And infants with severe dilation may also present with Perronneau syndrome.
This is a great mechanistic trap for the boards. Perronneau syndrome presents as a failure of upward gaze, but the mechanism has absolutely nothing to do with the cranial nerves in the orbit of the eye.
No, it is entirely supranuclear. The massively dilated third ventricle and pineal recess press down physically onto the tectal plate of the midbrain.
And that specific compression just wipes out the vertical gaze center.
Right. Now, the presentation changes completely when the skull is fused. Consider an acute obstructive hydrocephalus in a young adult, maybe from a suddenly bleeding tumor.
Now, the skull cannot yield an inch.
Not at all. The pressure builds exponentially, setting the stage for a catastrophic brain herniation.
The vignette here is a terrifying rapid decline. The patient will present with severe autonomic dysfunction, part of the Cushing reflex explosive projectile vomiting, due to pressure on the area postrema, a dilated and non-reactive ipsilateral pupil, and a rapid descent into a coma.
The temporal lobe is literally being forced down through the tentorial notch, or the cerebellar tonsils are being pushed through the foramen magnum.
That is a neurosurgical emergency where minutes dictate survival.
Absolutely.
So let's contrast that acute emergency with the slow, chronic presentation of normal pressure hydrocephalus. This brings us back to the famous Hakim triad: gait problems, dementia, and urinary incontinence.
Right. And the gait impairment is highly specific, it's wide-based, and the patient looks like their feet are magnetically stuck to the floor.
The term for that is an apraxic magnetic gait. But I want to challenge this triad from a test-taking perspective.
Okay, go for it.
Dementia and urinary incontinence in an 82-year-old patient. That describes a massive portion of the geriatric population. How on earth does a medical student differentiate NPH from standard Alzheimer's or Parkinson's on a vignette based just on those three symptoms?
The key is the sequence of symptom onset. The literature provides a powerful prognostic pearl here. In NPH, the gait disorder almost always precedes the cognitive decline.
Oh, wait, really? The order matters that much?
Oh, massively. On the exam, the Hakim triad is famous, but the order is crucial. If the gait impairment shows up first, there is a greater than 77% chance the patient will experience significant clinical improvement after a surgical shunt.
Wow.
But if the dementia is the very first symptom, the prognosis for reversing the cognitive decline with a shunt is incredibly poor, and the diagnosis might lean more toward a primary neurodegenerative disease.
So sequence is everything. Gait first means a reversible plumbing issue. Dementia first means something potentially darker.
Exactly.
Okay, once you recognize these physical signs, you have to select the next best step for diagnostic imaging. You are constantly choosing between a CT scan and an MRI on these questions.
And the acuity of the patient dictates the modality. If that young adult rolls in with explosive vomiting and a blown pupil, an emergency non-contrast head CT is the only correct answer.
I have to push back on that a bit. If the MRI is the ultimate gold standard because it distinguishes NPH from general atrophy and shows posterior structures clearly, why would a medical student ever choose a CT scan as the correct answer on a question?
Because triage physics override image resolution. A CT scan takes seconds, right? An MRI takes nearly an hour and requires a highly cooperative or sedated patient.
True.
In a herniation scenario, you simply need to confirm the massive ventricular dilation and rule out a massive hemorrhage so the neurosurgeon can immediately place a drain. You just need speed.
That makes perfect sense. And on that rapid CT, you are looking for the classic Mickey Mouse sign.
Yes, the Mickey Mouse sign is a fantastic visual mnemonic. The frontal horns of the lateral ventricles balloon out to form the ears, and the dilated third ventricle forms the face.
Seeing that pattern strongly indicates the fluid is trapped by an aqueductal obstruction.
The CT will also reveal the transependymal extravasation we discussed earlier. It appears as paraventricular hypoattenuation, basically these dark, low-density halos surrounding the ventricles where the CSF has been forced into the white matter.
Now, if the patient is stable, like our 82-year-old walking into the outpatient clinic with a magnetic gait, the MRI is the undisputed gold standard.
Oh, without a doubt. The MRI excels here because it can distinguish true NPH from ex-vacuohydrocephalus, which is simply a compensatory enlargement of the ventricles due to generalized brain atrophy.
It just visualizes the posterior fossa structures with such high precision.
Right. And it displays the transpendymal fluid as bright hyperintensities on T2 and FLAIR sequences. You may even see the corpus callosum physically bowed upward by the swollen ventricles on a sagittal view.
What about imaging traps? Are there diagnostic tests that test writers throw into multiple choice options just to distract students?
Definitely. A common historical trap is an X-ray of the skull showing a beaten copper cranium.
Right. This is a phenomenon where chronic pulsatile intracranial pressure gradually remodels the inner table of the skull, making it look like dimpled metal.
Exactly. While fascinating from a pathophysiological standpoint, plain X-rays are seldom indicated for diagnosing hydrocephalus today.
Any others?
Another frequent distractor is radionuclide cisternography. It's an older method of assessing CSF flow in MPH that has largely fallen out of favor due to very low sensitivity. Don't fall for it on the test.
Okay, so the imaging confirms the trapped fluid. The final phase of the clinical pathway is selecting the correct medical or surgical intervention to fix the pressure gradient. The first-line principle always focuses on etiology.
Right. If a craniopharyngioma is compressing the aqueduct or a massive cerebellar hematoma is blocking the fourth ventricle, surgical removal of that mass might restore normal CSF flow entirely. You might completely avoid the need for permanent plumbing hardware.
But when the cause is irreversible, like severe arachnoid granulation scarring from meningitis, we have to turn to surgical shunts.
And the workhorse of neurosurgery is the ventriculoperitoneal, or VP, shunt. This device routes a catheter from the lateral ventricle, tunnels it under the skin of the neck and chest, and drops it into the peritoneal cavity of the abdomen, where the massive surface area of the peritoneum absorbs the fluid.
And when placing a VP shunt in a pediatric patient, neurosurgeons intentionally leave the distal peritoneal tubing coiled and very long.
Right, because as the child grows taller, the tubing simply uncoils, preventing the need for constant revision surgeries to lengthen the catheter.
But what happens when the abdomen is hostile territory? Say the patient has had severe peritonitis, extensive abdominal surgeries, or is morbidly obese, making the peritoneum an unreliable drain.
Then the alternative is a ventriculatrial, or VA, shunt. The distal catheter is routed through the jugular vein directly into the right atrium of the heart, allowing the CSF to mix directly into the central venous blood.
There is also the lumboperitoneal shunt, which drains fluid from the lower spine to the abdomen.
Yes, but that is largely reserved for managing pseudotumor cerebri rather than classic hydrocephalus. You might occasionally see the Torkeldsen shunt pop up as a historical distractor, too. That was an older method routing the ventricles to the posterior cisternal space.
Good to know. But there is a modern alternative to mechanical shunts that is highly testable, the endoscopic third ventriculostomy, or ETV.
Ah, yes. The ETV procedure utilizes an endoscope to puncture a hole directly through the floor of the third ventricle. This permits the trapped CSF to flow straight down into the prepontine basal cistern.
So an ETV is essentially drilling a brand new drainage sinkhole right in the floor of the ventricle, completely bypassing a blocked aqueduct of Sylvius.
It is an elegant internal bypass, yeah. It is the preferred option for patients with isolated aqueductal stenosis because it frees them from the lifelong complications of a mechanical synthetic shunt. However, the literature highlights a critical limitation you must know for the MCCQE. ETV failure rates are remarkably high in very young infants and similarly poor in adult patients who have had a mechanical shunt in place for many years to treat an obstruction.
Let's think through the physiology there. If you've successfully bypassed the blocked pipe with the ETV, the fluid gets to the surface of the brain. Why would it fail?
Because the entire procedure relies on the arachnoid granulations actually doing their job once the fluid reaches them. In very young infants, those granulations are physiologically immature. They just haven't developed the capacity to absorb large volumes of CSF yet.
Oh, that makes sense.
And in adult patients who have relied on a mechanical VP shunt for years, their arachnoid granulations have essentially been out of a job. Through a use it or lose it mechanism, those granulations atrophy and lose their absorptive capacity.
Wow, so bypassing the pipe doesn't help if the final drain is permanently broken.
Exactly.
That is a phenomenal connection of anatomy to surgical outcome. Now, what about those acute emergencies? The patient herniating in the ER doesn't have time for a carefully planned ETV or VP shunt?
No, definitely not. In adults and older children, the immediate life-saving procedure is an external ventricular drain, or EVD. You drill a burr hole, pass a catheter directly into the ventricle, and vent the pressure out into a bag hanging next to the bed.
And for infants whose cranial sutures haven't closed?
A physician can perform a direct anterior fontanelle tap with a needle to immediately relieve the tension.
We also need to mention the diagnostic trial for NPH. Because the pathogenesis of NPH is so murky, neurosurgeons rarely commit an elderly patient to permanent brain surgery without proof it will work.
The standard diagnostic trial is a large volume lumbar puncture, commonly known as a tap test. The physician drains 40 to 50 milliliters of CSF.
And if the patient's magnetic gait improves significantly in the hours following the drainage, it is a strong positive predictor that the patient's brain will respond well to a permanent surgical shunt.
Right. And as for pharmacology, it plays a very minor role in all of this. You might see acetazolamide, a carbonic anhydrase inhibitor, used to slightly decrease CSF production at the choroid plexus.
but it's primarily tested as a medical management tool for pseudotumor cerebri rather than structural hydrocephalus, right?
Correct. Surgical intervention dictates the management of hydrocephalus. Pharmacology is merely a temporizing measure.
To bring all this together for your exam prep, success on MCCQE hydrocephalus questions really relies on recognizing the extremes. You must immediately differentiate the stretchy, accommodating skull of an infant from the rigid, herniation-prone skull of an adult.
Yes.
You need to know that a wide base gait preceding dementia in an 82-year-old signals a highly shunt-responsive NPH. And you must know that an acute presentation buys a rapid CT scan to save a life, while a chronic presentation buys a gold standard MRI to see the transependymal extravasation.
Beyond the exam, patient education is a massive part of a physician's role. Managing a surgical shunt is a lifelong reality for these patients. They must be taught to protect the superficial shunt valves under their skin from physical trauma.
And families must be educated on the subtle warning signs of increased intracranial pressure that signal a shunt malfunction or infection.
Absolutely. They also need clear instructions on securing antibiotic prophylaxis before dental work to prevent those devastating shunt infections.
Plus, as future clinicians, you will be responsible for helping pediatric hydrocephalus patients navigate the notoriously difficult transition from pediatric to adult healthcare networks, ensuring their multidisciplinary care doesn't suddenly evaporate.
Consistent, integrated care is the only reliable way to protect long-term cognitive and neurological function.
I want to leave you with a final provocative thought to mull over outside of the textbooks. We've established that congenital hydrocephalus can be clearly traced to mechanical blockages, like aqueductal stenosis. It's a physical tumor or stenosis blocking a pipe.
Right. It is localized fluid dynamics.
But the pathogenesis of NPH in the elderly remains a mystery, despite affecting hundreds of thousands of people over the age of 80. The pressure isn't drastically high, yet the fluid dynamics are failing.
It's puzzling.
So, could NPH eventually be viewed less as a purely mechanical syndrome and more as a widespread failure of the brain's glymphatic waste clearance system?
Well, the glymphatic system essentially uses the bulk flow of CSF to wash metabolic waste out of the brain tissue during deep sleep.
Exactly. What if this subtle chronic plumbing failure is actually a major under-recognized driver of age-related dementia as a whole? If the brain simply loses the ability to flush its own metabolic exhaust because the microscopic drains are failing, it completely reframes how we might view cognitive decline.
That's incredibly fascinating to think about.
It's definitely a compelling question to consider the next time you see an elderly patient struggling with their memory and their gait as you head back to your clinical rotations. Thank you for joining us on this deep dive. Keep studying hard, and we'll catch you on the next one.